Now we're going to do the lungs and thorax exam. We're going to start with the posterior thorax. And what I'm noticing about his thorax is it's nicely symmetrical. It is elliptical in shape. The AP to transverse ratio is 1:2. His breathing is unlabored. His color matches his ethnicity. His shoulders are symmetrical. And I'm going to now palpate. You tell me if you have any pain.
No.
I'm going to palpate the scapula and the rib cage, and there is, I don't feel any masses. He's saying that he's not having any pain. That's great. So now we're going to do symmetric expansion and tactile fremitus. So for symmetric expansion, we're going to find the bottom of his scapula, which is at rib 7. We're going to go down 2 more ribs to rib 9, and then our fingers are between 9 and 10, and we're looking, we're going to ask Mr. Moore to take a nice deep breath in and to let it out, and I'm watching my fingers move away and come back when he exhales symmetrically, and that just tells me that his lungs are inflating symmetrically. Now I'm going to do tactile fremitus. What I know about tactile fremitus is it is a series of vibrations that tells me that there is air throughout the lungs. If the tactile fremitus should be louder at the top near his larynx, and it should quiet down as we get to the bottom of his, or the bases of his lungs. So Mr. Moore, I'm going to put my hands on your back, and you're going to say 99 every time I move my hands. Okay? Here we go. Say
99.
Very good.
99.
Very good.
99.
Great.
99.
Excellent. So it was nice and loud up here, and then it got softer down here. Now we're going to percuss. If you could just kind of give yourself a little bit of a hug and lean forward. Very good. Now I'm going to percuss. You want to do a side-to-side comparison, avoiding the scapula and the spine. Here's 4. Here's 5. He has a very long thorax. Here's 6 and 6. And while I'm here, you can sit up. Great, perfect. Now I'm going to put my hand over the costovertebral angle and check for CVA tenderness. Does this hurt at all, sir?
No.
Great. Same thing over here. And that is negative. Now we're going to auscultate in the same places that we just percussed. And for purposes of the exam, I'm just going to zip through this. But if this was a real patient, you would auscultate on the skin so that you could hear the most clearly. And you're going to ask the patient to breathe in through his nose and out through his mouth. And I ask patients to raise their hand while I'm doing this because I have stethoscope in my ears and I can't hear them talk. But I would notice that they were raising their hand if they were in any distress. Okay? So here we go, Mr. Moore. All right. So 1 at the apex. And then moving down, here's 2, the side-to-side comparison. 3, 4, 5, 6. His lung sounds are clear to the bases. There was no rhonchi, wheezes, or crackles. Now we're going to have him turn over. Now we're going to look at the anterior thorax. Again, I see symmetry. Shoulders are symmetrical. His breathing remains unlabored or effortless. Clavicles are in great shape. I see no evidence of the use of accessory muscles. If I needed to, I could palpate, percuss, do tactile fremitus, and symmetric expansion. But because his breathing is unlabored, he had no complaints. All I'm going to do in the front is auscultate. So same 6 spots. So here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. Okay, if he were a woman, I would ask her to move her breast so that you could auscultate the middle lobe of that lung. And this concludes the respiratory lungs and thorax exam.